My name is Anantacharya. I'm the Chief of Neurology at Highland Hospital, and I've been here for 20 years in some capacity, a little bit more than 20 years. I've been here full-time for the last 13 years, and I've been the chief for the last 5 years. Well, alcohol is a very interesting substance. It's been used by people for a long time, back to ancient times when people started distilling things out of fruits and berries and nuts and things like that. And it's got a large place in social culture. It's a drug that's used to socially lubricate parties, and it's actually been shown in small quantities to potentially be good for you. The current feeling is that 1 to 2 glasses of alcoholic beverage a day may reduce the risk of different things like heart disease, possibly even strokes and Alzheimer's disease. And the reason for this is not clear. There's a lot of science behind it. So definitely has had its history. There's a prohibition that occurred in our country in the 20s and 30s, and it was determined that we could not keep it illegal for a variety of reasons, so it continues to be legal now. Interestingly, 50% of US residents have had a drink within the last 30 days. 22% of US residents have actually had binge drinking, which is defined as more than 5 drinks at a time within 30 days. And 6% of people have actually had 5 or more drinks for 5 days over a 30-day period. So it's a very common phenomenon that people drink a lot. It's a depressant in the central nervous system. It mimics the effects of certain neurotransmitters that can cause depression, such as Valium, benzodiazepines. They interact with a lot of the same receptors. It causes relaxation, and it causes social anxiety to be reduced, so it's very, very prevalent. It also induces sleep, so people use it to go to sleep at night. It does tend to cause early morning awakening and impaired sleep. So people who use it to actually go to sleep may find out that it's actually turning the other way on them. I've had a lot of experience with some in my population of people who may have 1 drink before they go to bed, and they've done it for their whole lives and they don't have a problem with it. I think it's when you start escalating doses and binging, I think that's the main problem. The common side effects are both acute as well as chronic. And the acute side effects basically fall under 2 categories. You can have intoxication, and intoxication even at levels, intoxication with lack of awareness of intoxication. And so that causes judgment problems. That causes motor vehicle accidents. It's a large factor in motor vehicle accidents statistically. It can also cause withdrawal effects. So the withdrawal effects are seen when somebody drinks a lot and they don't drink for some period of time. And because the brain has been relaxed by the alcohol, it can go into an agitated state. Okay? The common withdrawal effects acutely are people can come with seizures, and they can come with delirium tremens. And these are 2 of the most common presentations. They can come with both. These usually occur about 2 to 3 days after cessation of really heavy alcohol use. And what you can see is people becoming confused, people becoming tremulous, and people having very high heart rates. And at that point, it's necessary to admit somebody to the hospital to try to get them to come through the withdrawal without any bad side effects. There are a lot of things that happen to blood chemistries during withdrawal, that people can have electrolyte abnormalities that can cause other things like heart problems. So certainly management of the acute withdrawal is really important. The other thing that you can see is a withdrawal seizure, and these are unpredictable. I've seen people have withdrawal seizures a week or even more after they stop drinking, after we stop the alcohol protocol with benzodiazepines, and then they're looking okay. They can still have a seizure. And these people don't necessarily have epilepsy. They don't have seizures again if they're not drinking. Just to give you a couple of case examples of this. I have a gentleman who has been admitted to the hospital about 3 or 4 times this year for alcohol withdrawal. And he has a very supportive, caring family. He has little kids, and he works. And his trigger is that whenever he becomes unemployed or things go bad in his life, he starts drinking again. He has not really availed himself of the resources that we've been able to offer him, which are limited to start off with. And he's not interested in AA. He's tried that before. So I'm very concerned about how he will do in the future. His insight to the fact that he has this problem is fairly low. His family understands it quite well, but I think he's definitely someone where if we had more comprehensive treatment available to him, could probably save his life. And so we're trying to figure out what to do for him with that. I wanted to talk about a little bit more about the acute things that can happen when you come in with alcohol withdrawal. There's something called Wernicke's encephalopathy. And Wernicke's is due to thiamine deficiency because oftentimes with alcohol abuse, people don't eat very much and they don't get adequate nutrition, especially thiamine. And so when people come in with Wernicke's encephalopathy, they become quite confusional and delusional, and they're actually having hallucinations quite commonly. They tend to be kind of bland and not too agitated, just more confused. Wernicke's encephalopathy can progress in the chronic phase into something called Korsakoff syndrome. And in Korsakoff syndrome, what people do is they are not able to form new memories. So all new information is improperly registered and is not available to them, to come up as memories. And this can make it very difficult for management of the patient because they don't remember things. Their judgment is really quite poor. And so they can be very tough to manage in terms of behavioral issues. There are many other chronic effects with alcohol, and I think the difficulty with this research is that it's not likely that anybody will tell you how much they drink. And so the actual numbers may be different than, so you can't say that, having 2 drinks a day is probably okay because you don't know how much they really have. So that's certainly a problem. The chronic effects of alcohol involve several parts of the nervous system, and they tend to come on slowly over time. So patients may not actually notice that they're having these problems. Alcohol often helps with some of the symptoms of alcohol chronic changes in the brain and nervous system. So as long as they keep inebriated, they may not notice that certain things are happening. The main thing that happens is people lose coordination. And there's a part of the brain called the cerebellum that's located in the back part of the brain that has to do with real-time integration of sensory information while people are doing motor tasks. And so that's known as coordination. And people develop cerebellar degeneration with alcohol. And the first thing that happens is the walking goes. The midline part of the cerebellum is called the superior vermis, and that's the part of the cerebellum that's actually most impaired by alcohol. And so if you don't watch your patient walk, for example, you may not notice that they're having problems from alcohol, especially early on. This can go to an extent that's very difficult to manage. I have an example of a patient I met in the emergency room about 5 years ago, and when he first presented, he was extremely shaky. He was like this. And he also had fairly poor judgment, even though he looked fairly well kept, and he's a smart guy. And so I'll never forget when I was in the ER with him, and he said, "I need to go to the bathroom." And I said, "Just a second, I'll get somebody to help you." And he was already up, staggering to the bathroom, ready to fall. And we had to catch him and make sure he didn't. So since then, I've given him various medications to treat his symptoms from the alcohol, which are the incoordination and gait problems that he has. And he's done really quite well. He's actually walking a lot better. He's able to modulate his gait. He hasn't had any falls. And over time, he's improved quite a bit. Unfortunately, even though he's in a program where he has a counselor and he has a support staff, it's a pretty amazing program he's in, he still relapses. And so I had the instance where he called me and he wanted to know whether he needed to come in the hospital or not. And I asked him, so have you been drinking? And he said, oh, no, I haven't been drinking. And then I could tell talking to him on the phone that he was drunk. And so I said, well, why don't you just try resting a little bit at home and seeing if you feel better, or come in if you don't feel like that's going to work for you. And so he did get himself admitted. He called the ambulance. He got himself admitted to the hospital. And when I saw him in the hospital, he had a very red face. He was in alcohol withdrawal, and he was very embarrassed about what he had done. And we talked about it. And he's continuing on. He's in therapy. He's continuing to get treatment. Something else intervened in his case. He developed vitamin B12 deficiency. And so I was able to diagnose that and treat it with B12 in addition to the gabapentin that I'm giving him for his tremor. And he's slowly doing better. He certainly needs a lot of support at this point to stay in that place, though. So I do have concerns about that. Another thing that you can get is muscle disease, myopathy. Alcohol is actually toxic to muscle cells. So you can get breakdown of muscle cells in something called rhabdomyolysis, which is a very severe breakdown in muscle cells where it affects your kidney, affects your electrolytes, and you end up maybe even going into coma because of this. And so that's probably the most serious effect you can get acutely and chronically from alcohol use. Another chronic effect is a neuropathy, involvement of your peripheral nerves. And it can be a painful neuropathy, similar to diabetes in the sense that it starts distally in the extremities, usually in the feet, and marches up. And it can't be treated by anything really much except not drinking. There are treatments for the pain, but really, cessation of alcohol is the only treatment. There are also deficits in cognition that occur with alcohol, both chronically and acutely. And one of the things that happens is you lose brain cells. And you lose brain cells not only in the cerebellum, but throughout the brain. And the ventricles inside the brain get bigger over time because of the loss of the brain cells outside. What this does is it affects people's judgment. So in terms of adhering to a treatment program, they not only have all the things that made them drink too much to start off with, but they have the lack of brain resiliency to easily be able to change their behaviors because they may not understand at any deep level how harmful they are. So I think it's very important. The case example I gave about my patient who's been in treatment for all this time really underscores the importance of trying to get people to commit to a program, understanding that they may not have the cognitive abilities to process the importance of certain things, that they need external help for that, and that if we don't give up on our patients, if we continue to try to provide this treatment, we might come up with some good outcomes. The next topic I wanted to cover is cocaine. And I feel particularly strongly about cocaine because I see a lot of really negative acute effects in the hospital from it. I think of all the drugs, the confusion regarding the war on drugs and sort of the misrepresentation of various things in the media. I would say that cocaine is by far the most dangerous substance that people can use. Cocaine is a social drug in many settings, similar to what alcohol might be in more affluent settings. Cocaine can be something that people do commonly at parties and not realize that there are really bad possible side effects from it. I think I would really like to see ads up on billboards throughout our city that show what can happen to you from using cocaine, because I've certainly seen a lot of it. It's 1.7% of the US population over 14 has used cocaine. Mostly it's urban males. And interestingly, the cocaine use is decreasing over time. It's been down about a quarter over the last few years. And there are different reasons for that, perhaps, one of which may be because that methamphetamine use is becoming much higher. And I think most of the things I say about cocaine go for meth as well. They're very similar substances. They may have different cosmetic side effects, but in terms of what they do to your brain and heart, they're very similar. It's the most common illegal drug for hospital visits, about 40%. Cocaine is a stimulant. As opposed to alcohol, which is a depressant, cocaine stimulates your brain cells. And actually for centuries it's been used in certain countries in South America and Central America. People have been using coca leaf tea, very similar to how people use coffee in this country. And probably, I don't know that the epidemiology is there, but probably is a relatively safe thing to do. What happened was that people in labs made it much, much stronger, first with powder cocaine, and then really with crack, which was the huge influx into the major American cities in the early 80s. And that's created huge social problems. It's created a lot of hospital admissions and deaths. There are multiple mechanisms in the brain where cocaine works, but mostly what it does is it increases your dopamine secretion. So through a variety of means, dopamine is the chemical that's thought to be involved in reward. So when somebody does something that is beneficial for them, they get a little shot of dopamine in their brain, and they realize that's a good thing, and they continue to do it. Very important for things like learning. It's thought to be sort of the staple about how the basal ganglia actually learn how to do complex tasks over time. So it's very important. There's a lot of data that using controlled quantities of small amounts of cocaine can actually improve things like test performance. And so it's not all bad, but unfortunately the kind of cocaine that's available commercially is too strong and has a lot of really significant side effects. It causes euphoria, it causes increased focus, and decreased sleep. The flip side of that is that it can actually cause withdrawal symptoms that are very severe. What happens is all of the excitatory neurotransmitters in your brain are depleted by binge cocaine use. And then what happens is the person has no excitatory neurotransmitters and goes into kind of a stupor. I had one of my first cases when I was a medical student in the LA County admitting room. We had a gentleman who was laying in bed, and he wasn't doing much. His eyes were closed. He'd open them if you asked him. And when you asked him any questions, he would just look around and point out all the cats in the room. So he saw cats here, cats there, cats everywhere, different colors. He was able to talk about it, but he had no insight. He had no idea who he was. He had no idea where he was or how he got there. It turns out that we had a very good social worker at that time, and she was able to find out that he got on the Greyhound bus in New Orleans with a bag of cocaine, used it across the country, and ended up in LA in cocaine withdrawal. So he actually did pretty well. He recovered from that. I don't know what the follow-up was with him, but I was really alerted to what can happen to you when you're in withdrawal from cocaine. We see it very commonly here in the hospital. We see a lot of admission for cocaine use, and what we see is for the first few days they may be more sedated, not doing as much as you expect them to do, and that's pretty normal as you have cocaine withdrawal. There's also a lot of acute effects that happen. People become agitated, and there's a certain kind of agitation, psychomotor agitation, that involves a lot of bodily activity, can actually raise blood pressure, and actually can cause coma secondarily just by increased blood pressure due to all the agitation. It can cause seizures, and it can also cause bleeds into the brain. So acutely, cocaine can cause incredibly high blood pressures transiently, which can cause any weakness in any blood vessel to be exposed, and you can get a big bleed into the brain. So this is a really serious problem that you see with cocaine. Cocaine is also toxic to the muscle, so you can get rhabdomyolysis with cocaine that's very similar to what you might see with alcohol, and it can be very severe, and it can cause coma and even death if it affects your kidneys to that extent. Death is seen from cardiac manifestations of cocaine as well. Cocaine can cause arrhythmias, which is irregular heartbeats that can lead into the heart stopping and can cause lack of blood supply to the brain and death secondarily that way. I have a case that I'd like to talk about. This is a woman that came to our medical center about 9 years ago now, and she had actually been binging on both alcohol and cocaine. So it wasn't clear exactly which one was the main problem. Alcohol generally doesn't cause strokes, so I didn't think that was the main thing. She came in, she had been binging, she was altered, she went into coma over time, and she developed a movement disorder where she couldn't move her limbs appropriately. She looked really like she had Parkinson's disease. And what we saw in her brain imaging was we saw signal changes in deep structures in her brain, in the basal ganglia. And they actually went away with time, and slowly she recovered from this state. And I treated her with fairly standard agents for Parkinson's. And she stopped using cocaine. She went into treatment. Her significant other also stopped using cocaine. And they've been coming to see me in clinic regularly for the last 9 years. I think with adequate treatment for the Parkinsonism, which is pretty good now, you can hardly tell, she's thinking of starting driving again, and we're seeing if we can get her to do that. So that's a case of somebody who actually did very well, figured out that what's happening to her from the cocaine is not a good thing, and took measures to stop it. Unfortunately, that's not that common, which gives me a little concern. I have another patient who, he was an engineer, and he was working, and he was just doing cocaine with his friends. Nothing heavy in terms of what we might see, but he ended up having a stroke. And so he's weak on his left side. He's unable to work because he's weak. He's unable to get a job because nobody will hire him because he's obviously had a stroke and doesn't seem quite right. He seems very normal cognitively, and he comes to see me also, and he also relapses. So he doesn't like to tell me this, but he'll tell me, well, I used it a couple of times in the last few months. And I'll tell him, you realize that you could have another stroke if you use it at all. And I think that's the real point that I'd like to make, and that's the thing I'd like to see on billboards, that if you use cocaine just once, you can have a stroke or you can have a heart attack from it. And just a single event has affected this gentleman's life so much that, I think it's tragic. So the Parkinsonism comes from multiple strokes also in cocaine as a chronic effect. So what you get is you get blood vessels that change. You get arteriosclerosis, which is hardening of the artery from prolonged cocaine use and the hypertension that comes with it. And then you get angiographic appearance where you have beating of the vessels. And secondarily, you get vasospasm where the actual muscle wall in the artery spasms. And if you already have a narrowed artery to start off with and you spasm it, you can get strokes. So what you can have is actually small subclinical strokes. You don't see them until they add up to a certain amount, and you can end up with Parkinsonism from this. And I have many examples of patients who have had this. Very difficult to treat once you actually have brain damage in the form of strokes. But we do try to do that. It can also cause reduced blood sugar, and that can contribute to having seizures and coma in a secondary mechanism as well. I have a patient who came to me about 2 years ago after cocaine binging, and he was hospitalized and found to have strokes in both basal ganglia. And he developed a different kind of movement disorder than Parkinson's. He developed a hyperkinetic movement disorder where he was just moving around all over the place and couldn't control himself. And his mother came to the visit with him. He's a young guy, like 25. And his mother came to the visit with him, and I had to tell them that there's no standard treatment for this. We don't know what to do. And I suggested I can give him a medication we use for Parkinson's, pramipexole, and that it could either make him really psychotic and a lot worse, or it could really help him. And so they took that advice and they started the medication, and he did really well. He had therapy, he had speech therapy, occupational therapy at Fairmont, and he stuck with it. He's been abstinent from cocaine ever since then. And he's come to the point where now when he comes to his visits, he doesn't bring his mother anymore. He's independent enough to do that by himself. And so I attribute that to both his lack of chronic brain damage from the cocaine, that he was able to think it through and figure out what he needed to do, and the fact that he had enough support to do that. All of those factors led to what seems to be a really good outcome for him at this point with increasing independence.